Thanks. I'd like to start this morning, well, thanks for turning up so early on a Sunday morning, but I'd like to start, first of all, to tell you two stories about, or rather a story about two patients I recently saw in heart valve clinic. First was a 58-year-old man who 8 years ago had an AVR with a 25mm tissue prosthesis. And he was advised to have a tissue prosthesis by his surgeon because of his job, because he worked in a factory. But when you actually quizzed him about this, he actually worked in an office in a factory. He was a manager of a factory. And I saw him in a clinic. His last echo showed he had a gradient of 92mm mercury across the prosthesis, and he had class 3 angina. Okay, so that's the first patient. Another patient I saw in valve clinic was a similar aged lady, had an AVR with a mechanical prosthesis. 3 weeks after she went home, she slipped on some ice, hit her head. She got an extradural hematoma, needed neurosurgical evacuation. Physically, she recovered, but mentally, psychologically, it absolutely destroyed her. And it transpired that she'd gone to the anticoagulation clinic appointment the day after she was discharged, as we tend to do, and then she was given a 3-week appointment. So her INR when she had her injury was 9. Now, the reason I bring your attention to these two stories is that, number one, we are here talking about prosthetic valve choice in the younger patients. And number two, because there are risks, and as my slide says, there are evils associated with either types of prosthesis. And in the two cases that I mentioned, they're both completely preventable if these patients had been given correct advice. So my name is Norm Briffa. I'm a cardiac surgeon in Sheffield. As I've mentioned, I run the heart valve surveillance post-operative clinic. I'm president of the British Heart Valve Society as well, and the society I lead receives grants from these companies, but I don't have any personal conflicts to declare. So in answer to the question, I have absolutely no idea what the answer to the question, are we implanting too few mechanical valves? I know, as illustrated by these two stories, that keeping the patient at the absolute center of the decision-making process is key. And as I said, when it comes to the evidence, I'm going to concentrate on that group, the 50 to 70 age group. But what I hope by covering these topics today, I should provide some food for thought for you to help the patient make a correct decision. So a good place to start is actually to find out what's happening in current practice. And is there a pointer? No, okay. As you can see, this is practice in the United States. So if you look at the 55 to 64 graph, in 13 years it's gone from 10% to 50% use of tissue prosthesis. In the United Kingdom it's even starker. So the absolute height of mechanical valve, prosthetic valve use in the under 70s was in 1995. Since 1995, the percentage of prosthetic valves has been increasing. And this is very recent data that I collected myself over the past few weeks, knowing I was going to give this talk. So this is from cardiac registries of 6 fairly large units in the United Kingdom. And in 12, 13 years, we've gone from just over 30% to over 60% and these are patients having isolated AVR aged between 50 and 69. So a good place to start is the guidelines. Is this change in practice backed by the evidence? And a good place to look at for the evidence is the guidelines. Sorry about this. So the US and European guidelines are a bit different. The US guidelines are pretty generic. European guidelines are a bit more granular. So if we look at the age range where the guidelines suggest there is uncertainty, the US guidelines are pretty broad. So it goes between 50 and 70. So what they say is under 50 it's okay to put in a mechanical valve, above 70 it's okay to put in a tissue valve. So there's a huge range. That's the US guidelines. And the US guidelines lump mechanical and tissue together and lump MVRs and AVRs together. The European guidelines are a bit more specific. The age range is much smaller. It's just 5 years, between 60 and 65. So they say below 60, it's okay to put in a mechanical valve for an AVR. Above 65, it's okay to put in a tissue valve. Apologies to all my friends and colleagues around, thank you. Apologies to my friends and colleagues around the world who sit on committee guidelines, but I think it's important to try and look at the evidence behind the headlines. So let's look at the primary evidence for the two key randomized controlled trials. We keep going back to these because, number one, they were big trials. Number two, they'll never be repeated. And number three, in essence, nothing really has changed since the findings of those trials. So these trials, the data was generated, the trials were started in the late 80s. The trials were published in the noughties. So this is the VA trial, 15-year outcomes from 13 VA centers. 80% of the patients were between 51 and 70, so it covers the patients we're talking about today. Sorry, I'll go back. And essentially, the outcome from the American trial, the recommendation was that if you're under 65 and having an AVR, you should have a mechanical valve. If you're over 65, you should have a tissue valve. Then there was the UK trial, or more specifically the Scottish trial, very similar. Randomized controlled trial between a Hancock, I think Hancock and Carpentier-Edwards, and a Bjork-Shiley single tilt. And the main recommendation of the Scottish trial was that for AVR patients, if you have a life expectancy of 10 years or more, then you should have a mechanical valve. And the age range was about just over half of the patients were in the age range we're talking about for this trial. After the randomized trials came the simulation papers, and essentially these were modeling papers to try and establish from the data out there what is the ideal age to change over from a mechanical to a tissue prosthesis. And first was a UK paper, Sarbar and Storica, some guys from Papert and Prakash Punjabi from the Hammersmith. And they used data from a registry. They used data from Ken Taylor's audit, which he ran over 20 years. So they had huge amounts of patients to look at, over 5,000. And essentially what they discovered using this registry data was the age when the post-operative event-free survival was better with a biological prosthesis. Okay? And events meant you die, you bleed, or you need a reoperation. Okay? So the age at which it became better was 67 for males and 68 for females. The Dutch under Johanna Tuckenberg did a similar study. They didn't use registry data. They looked at published papers. And what they found is, again, when the age at which event-free life expectancy became better with tissue prosthesis was between 60 and 63. So over the past 15 years, there have been dozens and dozens of papers looking at this, looking at which is better, tissue, mechanical, in this age group between 50 and 70. And as I said, dozens. These are just some of them. And a student of mine, Charlotte Holmes, who's presenting this data on Tuesday, did a meta-analysis of these papers. Now, this is not a proper meta-analysis because the vast majority, just bar one, were not randomized controlled trials. These were retrospective series of patients. And what she found, she did a meta-analysis. So 3 of these papers, of these dozens of papers, showed superior survival with mechanical prosthesis. 1 paper showed superior survival with tissue prosthesis. But if you took the whole lot, they actually found no difference between the two. This is pure survival. And then if you looked at risks, so bleeds obviously favored tissue prosthesis, structure valve deterioration favored mechanical prosthesis. So we just go back to this. There is no clear, robust evidence to favor one or the other in this age group. Okay, maybe slightly in favor of mechanical. So it comes back to the class 1 recommendation of both the US and European guidelines, which is this has to be a patient-specific decision. And yet, you see what the patient's preference is, but you see all sorts of things. Which of the lesser of 2 evils will suit that particular patient in front of you when you come to discuss it? There are a couple of fundamental differences between these 2 evils. So bleeds on the one hand, structural valve deterioration on the other. Number one, bleeds are a problem with the treatment. Structural valve deterioration is a problem with the prosthesis. And even more important is the time frame. So bleeds occur within 6 to 12 months. Structural valve deterioration takes 10 years. And, you know, in the West, we all have a fairly short time frame of the way we perceive our lives. So, you know, structural valve deterioration is just too far in the future to think about. But the converse is also true, because if you come up with a solution that's going to cure bleeds, then you can see a difference within 6 to 12 months. If you come up with a spanking new tissue valve that's not going to degenerate, you're not going to see any difference for 10 years. So that's quite an important point to make. So let's look at the hemorrhage. So the first paper that studied hemorrhage or optimal anticoagulation in mechanical patients was this one from the New England Journal of Medicine. And they're the first to come up with these kind of graphs. So, you know, lower INRs, you've got more ischemic strokes. Higher INRs, you had more hemorrhagic strokes. They combined the two to present this event curve with 95% confidence intervals. And they come up with the safe range from 2.5 to 4.9. And then a whole bunch of papers started coming out. A Riva paper from France and the Gilia study from Germany. And that showed, in actual fact, it was safe to drop your INR down to 2.5. And by dropping your INR slowly, you had fewer bleeds without incurring the cost of greater ischemic strokes. And then there was an Italian study, St. Jude bileaflet valve. Again, they dropped the INR down to 1.5. Again, fewer bleeds without any increase in ischemic strokes. And obviously the PROACT trial with the Onyx valve, which did something similar. The other thing we found out from Eric Butchardt's work in Cardiff was the absolute crucial importance of INR stability. So patients whose INRs are all over the place, their survival is terrible. Whereas if you had nice steady INRs, your survival was similar to the UK population. And one way of ensuring, and a couple of very good papers, again, from France and Germany, one way of ensuring stable INR is home monitoring and point-of-care testing. The other thing, there are a couple of recent developments in anticoagulation. One is tacalferin. So tacalferin is very similar to warfarin, it's a vitamin K antagonist. The difference from warfarin is it's not subject to cytochrome P450 degradation. So it's not subject to this genotypic variance you get, so it's not, it doesn't interact as much as warfarin with other drugs and with things in the diet. The other problem with warfarin is the INR itself. The INR test is pretty, it's got a wide range of wide confidence intervals. And there's a new test called the fixed prothrombin test. It's far more accurate than the INR, and that in AF patients being shown to be associated with better outcomes. And obviously, atrial fibrillation. You can have a tissue valve, but as soon as you hit 65, your chances of being anticoagulated start to go up quite a lot because of atrial fibrillation. There have been lots of studies about attitudes to anticoagulants, so mainly in AF patients. And there's no doubt that the benefits of anticoagulation, okay, are invisible, okay, and tend to be downplayed. The risks of anticoagulation are very visible and tend to be exaggerated. And I suspect the same is in a population of patients who are undergoing heart valve surgery. So let's look at the other evils, structural valve deterioration. Yeah, number one, life expectancy is going up very rapidly. So patients, if you put in a valve at the age of 60, that valve has to last for 25 years. We know a lot about anticalcification treatments. This is the latest attempt. It looks fantastic new valve. The in vivo data with animals looks fantastic, but obviously we're not going to know for many, many years. And then there's valve in valve. Contrary to popular opinion, I don't think this is going to be a huge game changer, especially if we're talking about the very young patients, because various reasons, leaflet thrombosis and limited durability. The other important thing to mention, I'll quickly finish this, is patients are being echoed now. Now we've got heart valve clinics, so valve prostheses are under the microscope like they've never been before. And, you know, the standard definition of structural valve deterioration, if you actually go looking for deterioration, you can find it fairly early. Is this opening Pandora's box, or does it matter, or does it not matter? So, and then there's the healthcare economics. I'll skip that. So in the future, there's no doubt there's going to be safe anticoagulation care, I think there's going to be improved surveillance with PROMs, wearable devices. I think patients are going to be followed up, but probably remotely. I think there will be improved tissue prosthesis, better EOA, maybe rapid deployment devices. I'm sure Michael will tell us more about that. Personalized choice. How many in this room know that diabetics do worse with tissue valves? You know, a couple of big studies have shown that now. So maybe we need to identify the patients who will do well with a mechanical hood, who will do well with a tissue valve. Nice guidelines coming out in 2021. So in conclusion, in answer to the question, I'm sorry, I don't know. Patient preference should be the first and last of your considerations. Think of the lesser of two evils that suits that particular patient. Maintain a laser focus on the evidence. Advise on evidence and not prejudice. Okay? And finally, times they are changing because we live in a bit of a golden age in heart valve disease at the moment. Thank you. I'd like to thank these guys for giving me the data that I published earlier, and British Heart Valve Society, 7th, 8th of November. Put that in your diary. Thank you.